Good morning. Today I will be discussing with you on yet another important topic, hypertensive retinopathy. Systemic diseases, the role they play in the eye is tremendous, and it is very important to monitor the eye as well as the systemic involvement, the extent of involvement, the amount of treatment that's being taken, and the state of multi-organ involvement in identifying the extent of retinopathy. So, before I embark on retinopathy itself, it's important for us to understand we have most of the problems occurring in multi-organs because of accelerated hypertension, malignant hypertension or hypertensive encephalopathy. Hypertensive encephalopathy is very dangerous because it can lead to drowsiness and neurological involvement, symptoms of neurological involvement, and all of these can cause severe complications in the eye. Hypertensive eye disease can be classified into hypertensive retinopathy, hypertensive choroidopathy and hypertensive optic neuropathy. So, why is it that we need to classify this? What is the importance? Because based on the organ of involvement that is within the eye, whether it is the retina or the choroid or the optic nerve that is involved, we have complications which we need to deal with. Again, acute elevations of BP or hypertension is associated more severely with choroidopathy and optic neuropathy, whereas a persistently high elevation of blood pressure is more frequently associated with hypertensive retinopathy. So, this is the most frequent cause that we encounter in our day-to-day practice. Nevertheless, in each patient we have to look for choroidopathy and optic neuropathy as well. Retinal and cerebral vessels are very similar. So, that is the crux of hypertensive retinopathy. We as ophthalmologists play a very big role in identifying the state of cerebral vasculature by examination of the retina. We do not need any extensive imaging techniques, and hence we can provide a lot of insight into the status of systemic hypertension. And why is that? It's because retinal and cerebral vessels, the small vasculature specifically, they have common embryological, anatomical and physiological properties, and they are derived. It is derived from the diencephalon. So, that's what makes it very similar. So, it is derived from the diencephalon which makes it very similar. And in the earlier stages, a mild hypertensive change would be a generalized arteriolar narrowing. A 3.07 decrease in arteriolar caliber can cause a elevation of 10 millimeter. So, this 10 millimeter elevation is significant because we classify hypertensive retinopathy into mild, moderate or severe based on the elevation of the pressures, and 10 millimeter elevation is significant. So, any small change in the arteriolar caliber can reflect in the increase in blood pressure. Moderate and severe hypertensive retinopathy changes will be discussed now on. An indicator of systemic morbidity and mortality is largely dependent on a good ophthalmic examination. So, hypertensive retinopathy risk factors are, the most important risk factor is the duration of hypertension and also the height of BP. So, the amount of elevation of the blood pressure and the duration of hypertension are very important for us to see. Even if the patient comes to check his eye for his hypertensive retinopathy screen, we should go back and ask for a history of the duration of hypertension and for how long the hypertension has been present. Apart from this, you can also, it is important to note that chronic kidney disease, dyslipidemias, cerebrovascular accidents, coronary artery diseases, all these can predispose to worsening of BP. Obesity and diabetes mellitus are specifically associated with hypertension. Stress is a definite cause of increased BP. Substance abuse, especially alcohol, especially tobacco. Tobacco is more common than alcohol. Family history and ethnicity. People with African American and Southeast Asian races are more prone to hypertensive crisis, and a high salt diet. These are the commonest causes of hypertensive retinopathy which serve as the risk factors for the disease. So, hypertensive retinopathy can be classified into stages based on the clinical features and the pathological status. So, it's important for us to understand peculiarities of retinal vasculature play a large role. So, we have absence of autonomic nerve supply being a contributor, autoregulation. We have pericytes. These pericytes play a very large role. Pericytes are important to enable a good autoregulatory mechanism, and we also need to have an intact blood retinal barrier. This blood retinal barrier has to be intact, and autoregulation is the key in preventing retinal ischemia. So, if the autoregulatory mechanism within the retinal vasculature gets into a disarray, autoregulatory mechanisms key, and if that is not functioning properly, then we start having manifestations in the blood vessels. So, there are 4 non-sequential stages of development. This is a key word. When I say non-sequential, we are talking about the stages of retinopathy that need not go through these phases. I have enumerated 4 phases, but it need not always go through all the 4 phases in a stage-wise manner. And the first is vasoconstrictive phase, the second sclerotic phase, exudative phase, and the malignant phase. So, the vasoconstrictive phase is the first phase. It is a primary response of retinal autoregulation to hypertension. So, this is the first response you will see, the primary response. So, as soon as patient develops hypertension, vasospasm is one of the features. As you can see in this diagram here, these cells, all these cells in the intima, media and adventitia are there is a thickening, and so the lumen becomes smaller in size. If the normal lumen is of this size, because of all the increase in the layers of the arterial wall, the lumen size becomes decreased, and after some time it can even become further changes in the blood vessel wall, it can become even smaller. So, this vasospasm to an extent is required because it will maintain retinal perfusion, but increased vascular tone is one of the responses the body has to prevent a vascular wall. When there is a vascular wall injury, the increase in tone is one of the protective mechanisms that blood vessels adopt. So, as a consequence, we have retinal arteriolar narrowing. So, this it's a preventive response. This is something that the body does. So, this causes retinal arteriolar narrowing, and what we see clinically, this is the pathological mechanism, but what we see clinically is a generalized or a diffuse arteriolar narrowing. The normal, this is also important, when you are observing the retinal vasculature using a direct ophthalmoscopy, the normal ratio is 2:3, and arterial attenuation, that is AV ratio. So, arteries and veins, artery size is 2 and the ratio, and vein is 3. Arterial attenuation, so when the arteries attenuate, it becomes, this ratio of 2:3 can become 1:3. That indicates that arteries are narrowing in size. The next phase is the sclerotic phase. So, in this, there is acceleration of age-related arteriosclerosis in response to persistently raised BP. So, this is the important word. The BP is persistently elevated. So, in these patients, there is luminal narrowing like I just mentioned. So, what is this luminal narrowing? It occurs in 3 areas. One is in the intimal thickening. Then there is medial hyperplasia, that is more replication, and the third is hyaline arteriolosclerosis. So, this hyaline is important because this hyaline, when it is laid down, it makes the blood vessel lumen very small. Clinically, what you see is generalized or diffuse arterial narrowing and attenuation, which I mentioned in the previous slide. But one more point that we need to look for is the blood vessel. So, this is the vein, the tortuous vein that you are seeing. This is the tortuous vein, and this is the very thinned out artery. So, this artery will be bright, thin and linear with an arteriolar light reflex due to reflection from the convex blood column. So, this is, every artery will have a light reflex because of reflection of the light from the convex blood column, but here it will be exaggerated. In hypertension, because of the arterial narrowing, the light reflex appears exaggerated. Then the next, in a sclerotic phase, as we continue, as hypertension is advancing, there is progressive arteriolar sclerosis, and slowly the blood vessels will undergo opacification. So, this broadened arteriolar reflex is diffuse, but it is dull, and the next stage is copper wiring. Now, these are very important. copper wiring and silver wiring are very important words in ophthalmology. Copper wiring you will see as a dull orange reddish brown reflex due to a very thin blood column. So, as the artery is attenuating, the blood column is becoming thinner. So, you will have this copper wired appearance, and a silver wire is a white reflex that emanates because of severe arterial sclerosis. That means, by the time it reaches silver wiring, the arteries have become almost thread-like. So, these are, when you see these signs in the eye, you know that retinopathy has progressed to a very large extent. AV crossing changes is the hallmark of hypertensive retinopathy. We also call it AV nicking or nipping, and we generally like to look for this in the second AV crossing. That is, from the disc at the second AV crossing, we need to look for these changes. And what we see in the eye, ophthalmic manifestations can be Salu sign, gun sign and bonnet sign. It's very important for us to look for all this. In my class on direct ophthalmoscopy, where I have demonstrated how to do this, it will help you identify each of these signs. The Salu sign is a right angle deflection of the vein. The important word is right angled deflection of the vein. Gun sign is tapering of the veins on either side of the AV crossing change, and bonnet sign is banking of the retinal veins. So, when I say tapering, it will become like this. There is a tapering, and whereas if it's banking, there will be slight increase. That will be the configuration of the vessel.